And that's off.
On.
Okay.
What do y'all think? Can you hear me?
All right, and I'm going to introduce
Yeah?
you real quick.
Okay, good. Thanks, yeah.
All right, everyone, we're going to get started with our next talk about research initiatives on human trafficking, and presented by Cheryl Bodemer. She is an assistant professor and a certified healthcare simulation educator in the VCU School of Medicine Center for Human Simulation and Patient Safety. She received her PhD in public policy and administration from VCU with a concentration in health policy, an MPH from the VCU School of Medicine, and a BSN from the VCU School of Nursing. With her expertise in simulation and debriefing, she assists VCU faculty with the development and teaching of courses in the Center in Simulation-Based Education Research. In addition, Cheryl is involved in interprofessional team training in the simulation at VCU Health to promote patient safety. She has extensive experience in perinatal outreach, education, and public health surveillance, along with clinical practice in both neonatal and pediatric intensive care. Thanks, Cheryl.
Thank you. Appreciate that.
Yeah.
Wow.
Is this yours?
Didn't know I did all that stuff. Well, welcome. It's been interesting, and I've had a nice intro. You've had a little bit of intro into the research initiatives on human trafficking, especially from the public health perspective, since I'm a public health professional and worked in the field of public health a lot, intersected with education in the healthcare field, and also in surveillance. So we'll talk about a few of the opportunities that you may be able to get involved with, as well as what we're currently doing and some future choices that you may be able to make in terms of getting involved with research on human trafficking. So first, the goal is for you to be able to discuss a few of the opportunities. Obviously, I'm not going to go through all the opportunities that exist out there because I'm not an expert in where they are going on everywhere, but I'm familiar with a few opportunities which I'll highlight. And I know we talked a lot about labor trafficking and sex trafficking because human trafficking is comprised of both types of trafficking, but our research here and the research I'll talk about today is focused on human sex trafficking. So there's lots of opportunities for research. You heard about some of those from Kelly, and in terms of the public health perspective. And education of providers, I put that on top because that's what we do. And so our research is focused on education of providers. And there's many facets to that. You can look at the different modalities of education. There have been a number of different universities and medical students in undergraduate medical education, and then some in graduate education. Some of the centers in New York, and some of the centers in California, the University Health Centers, as well as in Vermont and New Hampshire, have launched different educational programs. And so you may be interested in those. You can just Google those universities and human trafficking medical education, and you can learn more about the different programs. You can look at, and what we wanted to look at, which I will go into depth, is how, what's the impact of an educational symposium like this that's multidisciplinary. And I'm going to present that to you based on our findings from last year's symposium. You could look at barriers to care. There's a lot of barriers to healthcare in all aspects of healthcare, but especially for those that people that are trafficked. And you know, we don't have a good understanding of what happens all the time to patients that we refer out to the community, as well as what happens when they try to seek care with us. What are their barriers? Are they financial? Are they transportation? Are they based on just being afraid to reach out and get help? So there's a lot of questions to be asked. And you know, that's really where you want to start, is what are the burning questions? And then to try to find out the information to substantiate what you're going to look into in terms of research. Screening tools, oh my gosh. Wow, it's overwhelming how many screening tools, and because of the intersection of all the different issues with human sex trafficking, especially be it domestic violence or drug addiction or depression or PTSD. So there's a lot of screening tools out there, but in reality, there are no validated screening tools to use for healthcare providers for human sex trafficking that are frontline or primary tools for screening, other than the green bomb tool that's used with in the pediatric population with adolescents. So there's a lot of opportunity to do research around different screening tools. And I'm going to talk about one research initiative that's going on across 5 different medical centers up in New York. And I'll talk about that in a minute. You could research resources. You could look at resources in your locality, in your region, in your state, national resources, all kinds of types of resources related to human sex trafficking. You could do research on that. You could research health outcomes. I think that's a big piece we don't understand a whole lot about, but we're beginning to understand, and that's where the survivor-centered or community-based research could come into play. You know, you don't have to just do it from the provider or the medical education perspective. You can go out and do it in the community. Partnered with community organizations like Faye's Impact Virginia. She's very interested in looking at this, and survivor networks and safe houses. So you have lots of opportunities in the community. Public health surveillance, again, Kelly referenced this. The data we have is what we have. It's based on reporting to a hotline. So there's a lot of opportunities for research on incidence and prevalence of human trafficking, both sex trafficking and labor trafficking, as she talked about. So, all right. So how are we tackling this challenge? Well, wow. Last year we had this fantastic group of M4 students that helped us put on this symposium, and they motivated our then M3 students, who are now our M4 students, to help us this year. Rah, rah, go everybody. This is our group from last year. And I'd like to thank them. And then one person that's not missing is a student who helped us with the research from last year's symposium to evaluate and assess how we did on the symposium, and his name is Matthew Wishnoff. And so he can't be with us today, but I thank you, Matthew. He's an M4, and he helped me. He was instrumental in getting all the data into the database so that we could talk with biostatisticians here at VCU to help us analyze the data. So, oh gee, wow. Hey guys, does this look familiar? So a little bit about this survey research we've embarked on. This is from last year's symposium. It's similar this year. The questions are almost the same. We added a few more answer choices, and so that's all we did, because we want to continue with building our database of evaluating our symposium. Now, some of the things in the symposium have changed this year, so we'll evaluate separately this year's symposium from last year's. But there's a pre-survey and there's a post-survey, and the survey tool was actually adapted from a survey that was done about 4 years ago and was published in BMJ Open. And so they wanted to be able to have people to share the survey and others to use the survey tool for research. That's the ideal mentoring, guys. When you can develop something and something comes out of your research that other people can replicate. This transparency, this replication, it's awesome because it really helps us do research a lot easier and a lot faster. If we can determine what somebody else has done and look at what they found, and then we say, hey, we want to do this kind of research. Will this tool that they used, or these methods that they used, the design that they used, can we adapt that to our population and our environment and our culture and our people? So that's what we did. We adapted the survey. So this survey was actually, just a little background, it was Dr. Ross and his colleagues, and they did this with the National Health Service providers in the UK. It was, oh gosh, I think they had over 1,000 surveys across maybe over a half a dozen different centers, medical centers that provided care. And so they did education and training and talked about their policies and procedures with their folks, and then they did this. So they did this pre-post survey to measure how good of a job they did on educating their healthcare providers. All right. So with that, we encourage you to please fill out the survey. It's totally voluntary, but we love for you to have a pre and post survey to give us so we can see what your knowledge and attitudes and opinions are, and whether those changed after you attended the symposium. So last year, this is our poster, and we're getting ready to present this at the Association of OBGYN professors and residency education in sunny Orlando, Florida, in the end of February. So these are the results of this, how we studied, what we did to study our symposium from last year. And of course, we just, first started out by talking a little bit about the purpose and to gauge the impact of this human trafficking symposium on the beliefs, knowledges, and experience of its attendees. And so we did the same pre-post training surveys. They have 39 questions. Like I said, they're adapted from that PROTECT questionnaire. And Matthew entered all the data into REDCap, and it was analyzed by the biostatisticians. We used some measures to look at the mean differences and comparison of pre-post. We used actually Wilcoxon's signed rank and McNemer's chi-square. And we came out with some amazing results. I mean, the attendees last year gained so much out of the symposium that look at these results. So these are the median scores, 2 to 3, 2 to 4, 2 to 3, 2 to 3, 2 to 4. You say, oh, that doesn't seem like a whole lot. But look at that p-value, 2.12 to the minus 15. I can hardly put 15 zeros in front of that p-value. Extremely significant results. We had 121 matched surveys. So 40% of all the surveys, 48%, were analyzed and included in the study. So some of the things we found out, 73% of the attendees had not received prior training in human trafficking. And only 12% of the attendees reported previously being in contact with the potential victim. That was on the pre-survey. 12% of people thought, well, maybe I had some point had contact with a potential victim. Compared to the pre-conference surveys, like I said, there was a significant improvement in knowledge of identification of the survivors, communication approaches, comorbidities that accompany trafficked persons, and reporting resources and policies. There was also an increased incidence in perceived confidence in using a trauma-informed approach, which is what we are going to talk about some more this afternoon, and the attendees' ability to assist, protect, and refer victims. Real important stuff. Now, as a researcher, I also, we have to also report things that were negative. So there were a couple things that were negative, but they were very small questions, small amount of questions. There was no significant difference about beliefs regarding persons that are trafficked. Now, why do you think that could be? Anybody know? Because you want to ask those questions. Well, why was that?
The population you were giving the survey to.
Yeah. Maybe they already knew enough and had formulated some beliefs about human sex trafficking. So those didn't really change. That's okay. But I want to report it, right? So in the end, baseline knowledge and confidence in recognizing and responding to persons that have been trafficked, that's limited. That was limited. That was clear. No arguing that. Changes in the domains after attending the symposium were significantly improved. Wow, we hope that happens again this year. We'll see, right? So based on this data, what we wanted to find out was, did we need to do some additional training? Well, that was easy. The answer was yes. And then we thought about, well, what else do we need to study related to this? So we want to measure how the attendees applied the knowledge in their realm of experience seeing patients, wherever they were, if they were medical students, if they were mental health providers, if they were in social services, if they were nurses in the ED. I mean, if they were community advocates or safe houses, if they worked there, if they were counselors. How did people apply this knowledge? That would be a great thing to study for future research. And also to identify what are some barriers to implementation of this knowledge, or barriers to identifying persons that are trafficked. So those are really some future things that are of interest to us that we would like to pursue. So there's a couple ways we're going to do that. One way in particular is more education for our medical students and healthcare providers. So there's an M4 human trafficking clinical elective. Our professor, Fidelma Rigby, Dr. Fidelma Rigby, she heads that up. And so M4s can sign up for that clinical elective, and they come to the symposium, and then they complete the surveys, and then they go out to the offices and do their clinical observations. And they also educate the staff in the offices. So we're spreading awareness of the issue, right? And then they're going to measure that. Well, how do people respond? What did they know? Did they learn something from me being here and helping them become more aware and to recognize and to identify and to start helping patients? So that experience, and for them, we also launched our new training modules that we developed. So, and those are also going to be launched this month, February, in the M3 OBGYN clerkship. So you just heard a medical student, our friend from Geisinger, and she presented what she did, and she said, wow, wouldn't it be cool to have this in the clerkships? So that's what we're going to do. So Dr. Rigby, she's going to implement this new curriculum, which you'll hear more about this afternoon, in the M3 OBGYN clerkship. We're pleased to let you know that we were also asked to present it at our National Simulation Conference last month. And you say, well, simulation, why did you present that in simulation? Well, we actually used a standardized patient. Does everybody know what standardized patients are? Does anybody not know what a standardized patient is?
Tell us.
So a standardized patient is a person that's interested in being involved in educating. And at our school, it's medical students, residents, and clinicians. And they come on board with us in the simulation center, and we train them in a standardized role to be the patient. And then you have a one-on-one encounter with the student or the healthcare provider that's training, and they give them feedback about their interaction with them. And it's about a specific topic. So if you choose, they also are used for testing medical students in their structured examinations that they have to pass for physical exam and history taking before they graduate from medical school. So we have 70 plus standardized patients employed right here at VCU in the simulation center to do this. It's really a great experience to have a one-on-one encounter with a standardized patient as a student. If you talk to any students, I'm sure they'll let you know what a valuable experience it is, talking to a real person instead of just sitting and watching a video. But it's time-consuming, so it's hard to interject new things into the medical school curriculum, and it's hard to get providers that are already working into the Sim Center. So what we decided to do was we videotaped this encounter to be part of an educational module. So we're going to evaluate that, and then we'll release that and share it with others to use in their curriculums. Resident education initiatives. We're beginning to do some work in this area, in training residents. And other VCU students from the other campus have gotten involved in the human trafficking interest group. So that's a good thing. So we're spreading the message. So this is kind of one of the slides that introduces the videos and the theoretical model of change in application to human trafficking from our curriculum. And I'm not going to go into the details of this because you're going to hear about it right after this from our students. All right, so again, for this new learning module that we're releasing next month, assessment and evaluation-wise, there's a pre and post survey, which is an abbreviated version of the survey you took today, and a 3-month follow-up survey. So the follow-up survey does address those questions of how did you apply this knowledge that you learned? And were you able to identify any trafficked persons and be able to help them? The IRB application for exempt status, because everything will be de-identified and will follow the protocol for confidentiality of responses. IRB exempt, approved yesterday. Yay. Go team. All right, I promised you just a snapshot of other research in human trafficking that's going on. This is in regards to a screening tool. So the group out of New York City, out of the Bronx and Mount Sinai, they put together a team who are researching a screening tool, specifically for healthcare providers, a rapid assessment screening tool called Building RAFT. So RAFT is their acronym. And so they're working on the derivation and validation methods. And it's going to take 3.5 years. It takes a long time to get the power to screen enough. It's a randomized trial, so that's nice. There's no bias in they try to get rid of the selection bias on who they pick walking through the room of the emergency room door to participate in this. So they've randomized it. They have collaborators from 5 different EDs. It is a screening tool for adults, so it is specific to adults. And like I said, it's in the ED setting, but their goal is to make this transparent so others can reproduce and externally validate this tool. So this is a great opportunity for other health centers to jump on board with. But they've just started this. They've published this initial peer-reviewed outline of it. And what happens with their thoughts is that this is a rapid screening tool that has 5 items that in 5 categories that healthcare providers can administer if the ED patient is stable. So if it's not something that's an emergency. And so they randomized based on the time of the person entering the ED. That's how they randomized the selection. And they are going to look at this and hopefully to get enough participants to agree to do it. And then what happens is if they, at the time they're doing this study, for those that are enrolled, if they identify you as being a potential victim of human trafficking, and they get you to cooperate, then they will put you immediately in touch with a social services person, the way I understand this works, who will then administer a long validated tool for human trafficking. And that's both labor trafficking and sex trafficking. That's the violence screening tool. So you can look up their study and read more about it if you're interested in that, but I did want to just give you an example of some research currently that's going on that's replicatable. And of course, Faye pointed out this 2020 update on human trafficking, these guidelines for healthcare providers from the state of Maryland. Some states have done similar things. This is a really, I think, well done publication, and it does pull from national guidelines and national screening tools like you saw. But most screening tools, face it, are designed for social services, mental health providers, someone that has 45 minutes to an hour to screen a patient, not for the frontline provider. So it's important too that, you know, I read the training for those screening tools in the RAF study. It takes over like 16 hours to train their raters. So there's a lot of work that has to go into training people to do these kinds of screenings, even the abbreviated screenings. Oh, I'm muted. I don't really know what to do with that. But anyway, so I think, have you gotten a flavor for future directions in research? And if you're interested and you want to become involved, I don't want to repeat myself, but I did want to talk a little bit about, I think it's important that even if you don't want to get involved in formal research or just say, gee, I really don't know how to do that. I mean, there's a lot of people at the university that do all kinds of research, not just research of, you know, numbers and data, but research that's smaller in scope and descriptive, like case study research, you know, the kinds of things that we can do to apply to education and to utilize that are very interesting. So it kind of brings it home when you talk about using case studies of persons that are affected by human trafficking and stories from survivors. So there's a lot of different types of research that can be done. And the statewide coordination of efforts and the importance of communication across disciplines we heard about this morning. You're going to hear more about that this afternoon, I think. No, tomorrow afternoon, right? From our new statewide coordinator and from the Department of Justice, Homeland Security, thank you. Let's see, one thing I didn't put on there, legislative. So you can do research on legislation, policies from different places, the policies that we have, the effectiveness of the policy. We talked a little bit about application of policy. Somebody asked a great question. Well, this mandate that passed about school 2012, hello, we're in 2020. How come all our schools don't have educational programs for at least train the teachers and the counselors and the staff?
There's only 6 counties in Virginia that have prevention education.
Wow, only 6. Yeah. So, okay, there's a lot of, so you could research, well, why? Is it funding? Is it lack of awareness? Lack of motivation? What is it? Why aren't we there for a policy that's so old? And you know, this happens every day in life, not just with human trafficking, but it happens across a lot of policy and legislation that's passed, and is it implemented? So, you know, the key is implementation and then evaluation of that implementation. You know, it's that rapid cycle assessment. I'm really focused in quality patient care and how our how students translate their education and their educational outcomes translate into their clinical practice. It's that big circle. And how can we do better in educating folks to improve their practice in whatever realm of practice you're in, whether it's teaching, counseling, healthcare, right? I mean, that's a gold standard, is translating the research into caring for people and making it better, right? Okay? Questions? No questions? Look, the sky's the limit. Wow, is this amazing? You know, the day we were doing all our talks in San Diego, I woke up and looked out the hotel room, and this was my vision. Look at that, that's amazing. If the lights were off, you could appreciate the colors better. So maybe just a few minutes, I'll take some questions, and I just like you to spend a few minutes in your table group, maybe brainstorming about some thoughts about where your interest would lie in in looking at or investigating different aspects of human sex trafficking, or your thoughts on getting involved. Yeah.
Could Alina just make mention about the breakout session, like where it's going to be?
Oh, yeah, sure. Okay, we'll take questions and then brainstorm, and then we'll do that. We have plenty of time.
Just a quick note that the breakout sessions, they're going to be repeated twice, so you'll be able to go to 2 sessions out of the 3. So we're going to have a session in this room, and in the 101 room, and there are going to be signs outside the room with the title of the session. Okay, so I just want to let you know that after we finish here, you can go to those rooms. Okay, go ahead, Joe.
Oh, questions?
Well, no, I
Yeah.
thought, I didn't know that. I was going to ask
Oh.
about the stages of change because I didn't think I was going to
Oh,
get
yeah,
that.
yeah.
Never mind.
So, right, so the theoretical stages of change, like you probably know a little bit about this, the theoretical stages of grief,
Well,
right?
it's a recovery model
That's
for
right.
where I work.
Great.
So
Fantastic.
I don't have to ask now because now I get to go
Yeah.
to that breakout session.
So that's part of the best practices that's combined with trauma-informed care that's recommended for approaching trafficked persons. And so we incorporated, we based our education on those modules, a little bit of background training about those modules. Any other questions? No? Well, maybe you, if you would spend just a few minutes discussing at your table ways that what you do in your profession, how you could contribute to doing some kind of research surrounding human trafficking. So you might meet someone that's already doing it, and then, or maybe not, and maybe they want to say, well, why don't you call Cheryl, because that's what Dr. Rigby does. Does this require IRB? Oh my gosh, that's too complicated. I don't know what's going on. Cheryl, can you tell me? I said, well, I could try. We'll give it a shot, see what you can do with it. Thank you.
What's IRB mean?
So IRB is the Institutional Review Board, and that organization exists at every entity where human subjects research is done. And so your research may not be specifically directly interacting with human subjects, but it could be about human subjects, right? So if it's exempt, you go through the process of writing it up, answering 50 questions, send it in, and they tell you, yes, this looks like this is ethical research. So based on,
So you don't have to do that for this study or just
so
in general?
this one you don't because it's totally anonymous. But if you're going to be rigorous and use any type of identifiers to match in order to match surveys and then follow up with people, so then you just have to follow the guidelines for ethical research. Ethical standards of research basically is what they ensure. And of course, if it's clinical research, then that's a very much more in-depth level of scrutiny to ensure that there's no harm to persons.
Got it. Okay.
Or they're not, in other words, harmed by your research.
Got it. Okay. Yeah. Well, I was going to ask you about the stages, the action stages or whatever.
Sorry, I don't want to interrupt these great conversations that I'm sure you all are having, but I wanted to make sure that everyone knew about the 3 different options of the breakout sessions that we're going to have and where they're going to be, just so that you can keep that in mind over the next few minutes and then transition to those places once your conversations wrap up, okay? So the first is physician survivor mode. And so this is going to be a survivor-clinician conversation about building positive healthcare experiences for survivors of human trafficking. Here's a little quick blurb about it. A clinician's approach to a victim should be gradual and non-threatening, and building rapport is the first step in trauma-informed care. Join survivor expert Melissa Early in a Q&A on victim-centered approaches with Dr. Fidelma Rigby and Dr. Robin Foster. That's going to be held on this side of this room. We're going to actually bring down this partition, so it'll be 2 separate conversations taking place. The one taking place on this side of the room is going to be about stages of change. This is going to be, it is important to understand the mindset of a victim of human trafficking. The reason behind this is due in part to the amount of power and control a trafficker exerts on his or her victim, which can create barriers to self-identification or leaving a trafficking situation. Most victims will not feel motivated to change if they feel they are not supported in their efforts or feel they must defend their actions. That said, a clinician's primary goal is not to rescue or seek disclosure, rather to meet survivors where they are, build rapport, and move them toward healthier choices and behaviors in a spirit of shared decision-making. Our speakers will explain how applying stages of change model to our practice will help survivors feel respected and motivated to make the change necessary in their lives. That will be held on this side of the room. Again, a partition will go down, 2 separate rooms will form in this larger space. On the side, back in that room where we had our lunch discussion, room 101 over there, is going to be living in survival mode. Poor mental health is the most dominant health problem in survivors of human trafficking because of the prolonged exposure to repetitive and unpredictable physical and psychological violence. The consequence of being commodified and monetized make mental health outcomes from trafficking even more devastating, far-reaching, and long-lasting. Survivor expert Pamela Lynn Hawk will share what it's like to live with complex PTSD and why clinical approaches that promote patient safety, autonomy, and control are crucial to a survivor's lifelong healing and well-being. Again, that will be held in that separate room. Okay, I just wanted to make sure everyone knew what your options were and that you'll have the opportunity to go to 2 separate sessions at 3 and then 4 p.m., okay?
So when are we starting?
3 p.m. will be the first one. So please continue your conversations. I apologize for interrupting.